How long after hydrocortisone shots do you need to wait before having surgery?
So here's the dogma. I love this question.
Is dogma.
Here's dogma. People come in and said, I had an injection 3 months ago. I can't have surgery. That's dogma, okay? If you look at the literature, for years there was no data on it. So one study came out that said there may be a slight increased risk of infection within 3 months. If you're good at looking at the studies, which we are, they grade the studies a level 1, 2, 3, 4, 5 evidence. Level 1 is a good study, level 5 is bad. It's a level 3 study. It means it doesn't show cause and effect. So with that, you could make a judgment error with the patient, and it's good not to do it right before the surgery. There's no absolute time. The risk of any infection decreases after a month, and it increases sequentially. So there are occasional times that patients have an injection and the surgery becomes, but there's no definite answer like we said in the beginning. But to be cautious, it's usually 1 to 3 months you want to be safe.
Yeah, I agree. Months, I mean, it's more with the steroid injection. There was one study that came out that said 3 months you have to wait. And we used to do that. But now I'll do even less than a month in a healthy patient.
Yeah.
Again, are you diabetic? Are you overweight? Do you have other health issues? Those things play into it. If, it can be 1 to 3 months, just like you said.
Are ACLs repaired during total knee replacement surgery?
Well, good news for you, we take out the ACL if it's there. So if yours isn't there, it doesn't matter.
Oh, okay. So the total knee replacement takes care
We
of
take out the ACL. You can do two things. You can, we don't need to get that. We take that ligament out.
Okay.
And then the choice is there's modern type of knee replacements where the PCL, which is the other ligament in your knee, some surgeons decide to save that ligament and use what's called a CR knee, a cruciate retaining knee, and others choose to use a cruciate substituting knee, right? So they're just different style knee replacements that we use. But don't worry about your ligaments, we take care of that. Okay. I'll tell you what I tell all my patients. God gave us the best set of joints we're gonna ever have, okay? And if you have a surgeon like him or myself or another surgeon tell you that they can do the same or otherwise, they're either God or a liar, right?
Okay.
And my guess is they're the latter.
What is the difference between a lateral and anterior hip approach?
It's a great question.
Well, since I don't do hips, I'll answer that question.
Go ahead. Go ahead. By the way, he did hips a long time ago. I've done some revisions on his hips that he did 30 years ago. So
why did you revise them?
Because they wore out. Oh, they were in perfect position. They were great. There are different approaches to the hip. There are actually even more than 3 approaches, right? There's, like you mentioned, the direct anterior approach. There's a lateral approach, the Harding approach, and there's also a posterior approach. They're the 3 main approaches to hip replacement surgery. And they all have their advantages, and they all have their disadvantages. The anterior approach really, about maybe 10 years ago, maybe 10 or 15 years ago, came back into vogue. It's actually an old approach. They're all old approaches. But there was a surgeon, Dr. Meade, who really brought it to the forefront. One of the orthopedic companies grabbed onto it, and they made a big push for it. What I tell my patients is, so I was trained, I've done all 3 approaches in my lifetime. I was trained as a resident on the posterior approach. When I did my fellowship in Philadelphia, where he trained with Dick Rothman and Bob Booth trained me. They were the lateral approach. You had the hip done. It was called the Jefferson approach, right? And then my boss, my mentor and his mentor split, and it was still the Jefferson approach, right? So then I came up here, and when the anterior approach became in vogue, I learned how to do the anterior approach, and I probably did about 50 or 60 anterior approach. So I've done all 3 approaches. Here's the way I describe the approaches. It's like 3 different ways of getting to the mall, right? You get to the mall all 3 ways you're going, right? One might be a highway, one might be the back roads, one might have 2 or 3 lights, one might have a pothole, but you're gonna get to the mall. What you want is the guy driving the car that knows where the pothole is, that knows how to beat the lights, and knows how to get to the end, right? So there are guys in the Valley that do a great job with the posterior approach, guys in the Valley that do a good job with the anterior approach. There's one guy in the Valley that does a great job with the lateral approach. But again, I've done all approaches, but you should never go to a surgeon and say, I want the approach, right? You never go to a mechanic and say, I want you to fix that car this way, right? You want to have the trust. The biggest thing for everybody in this audience that I want to explain to everybody, and I know Tom will agree with me, is you have to trust your surgeon. If you don't feel good with your surgeon sitting in the room with him or her, never let yourself end up in an OR with that person. You have to feel comfortable in the room with the person, right? You are looking for a surgeon. You're shopping, and you have to shop for the right surgeon for you. There might be a very talented, very good surgeon you just don't get along with. So there are other surgeons, move on. This is your hips, they're your knees. You need to find the guy that you fit in with and let them do the work. You trust that they know the best thing for you. Did I answer your question? I hope so.
Is there a difference in recovery?
No, and that's a great question. And if you talk to somebody that does the anterior approach, they'll say, yeah, it's great, you're up that day. Well, guess what? Somebody does a lateral approach, you're up that day too. And somebody does a posterior approach properly, you're up the same day too. And you know, a lot of the hip replacement surgery is the same as knee replacement surgery, right? It's the other things along with the surgery, right? Of course, minimal incisions, making smaller incisions, less tissue damage, that's going to really pay off. But a lot of it's the multimodal pain control, getting you up quickly. That's the stuff that gets you better. All three approaches are very, very good approaches in the right hands.
What type of pain methods are used after surgery?
So we individualize everything, and I'll tell you what I've learned over the years. And as I address this, I'm going to say, in case you get tired of listening to me, I put a plant in the audience, and it's Bud Coates over here, just in case you didn't believe me, but he had both knees replaced in the last year as an outpatient under our rehab protocols. And so if you want to ask a patient, not Eric and I, he's here. But so we individualize it. What I found out, and it's my opinion, and Eric may have a different one, but I found out over the years, hundreds and hundreds of patients, the patients that went to therapy the first week did worse than the patients that went home and listened to us. And you know why? Because therapists schedule patients once an hour. And you know what? The day after surgery, you don't want to have an hour's worth of therapy. So what we teach patients is to do 5 minutes of exercises once an hour. For 8 hours in the day, that's 40 minutes spread over the day. When those patients show up a week later, they were doing better than the ones that went to therapy. Like you, some people, if they're lagging or they go, I need some help, then they go to therapy. We go, you're a great person to do outpatient therapy. And that's how we individualize. If you're an all-star and you're motivated and you're like Bud, who ran Rodale Press Fitness Club, well, he could do it on his own because he knows what to do. But if you live at home like our woman up top who didn't want to be a UPS package, then we could do home therapy. So we have a lot of options for everybody's different situations.
Yeah, I'm a little slightly different. I'm kind of a fan of outpatient therapy. I send my patients to outpatient therapy, but you know, it's, again, this is what's amazing about joint surgery, right? If you go to a joint surgery meeting, you'll have 10 guys and you'll have 10 different answers, right? Because there really isn't a right and a wrong answer. I mean, I see through my experience with my patients, I like to get them up as quick as possible and I like to crack the whip as quick as possible. Get them working in outpatient therapy, but the therapist understands that, you know, there are different speeds, right? Like for you, somebody might need a little more help, be a little slower. But I think it's important. I like the getting out of the house thing. I like getting in the car. I like getting somewhere because for me, therapy is more getting from the car to the therapist, right? Walking out of the car, getting into the car, getting out of the car, walking to the therapy, ice, other modalities that the therapist can do in the therapy that you can't do at home with yourself. So that's why I send as many of my patients that I can to outpatient therapy. Now that's with knees. Hips are a totally different story. How many people here have hip replacements or had one? I know you do. See, I didn't have a plant, but some of my patients showed up. But a hip replacement, you don't need...
I have to pay them.
Yeah, well, you know, that's why I wear suits, you know. What am I gonna do? So anyway, Hip replacements are different than knee replacements. Knee replacements, you need to work a lot more. A hip replacement, you could kind of lock in a closet for a month, open the door in a month, and the patient says, I feel great. That being said, it's important for the patient that has the hip also to move and to walk and to do those things. And a lot of patients, if you tell them to just stay home, that's kind of what they do. They stay home and they sit down in their chair. All right? I just like the act of going to therapy as much as therapy itself.
How do you know if you need a knee revision?
So it's almost the same thought process as the initial knee replacement. When your quality of life is terrible, the knee hurts, it swells, and it's painful. And then we have things that we look at. The big two reasons, another misnomer in orthopedics is why you need knee replacements, that they wear out and they're going to be gone in 10 years. In reality, the top two reasons to need a revision knee is one, the parts become loose. It's like a crown on a tooth. And if that becomes loose, it's called aseptic loosening. And then you have to go back in and take that out and replace it. Some of the newer technology avoids that. For 50 years, we used to glue parts in. Now, a lot of the newer technologies, we don't have to use glue all the time or methyl methacrylate, but it grows right onto the bone like a dental implant. So that, over the years, hopefully will avoid a lot of the loosening. And the other things is catastrophic problem, infection, fracture, those sorts of things. And we could tell that by x-ray. So, you know, if you have symptoms and it correlates with one of those problems, then we could look at a revision of the knee or the hip, Eric.
Yeah. No, and I agree with Tom. I mean, I think, and I'm doing more and more cementless knees. That's what they're called. They're different type of knees, right? There's ones that use cement, like Tom said, and ones that don't. And I think years to come, we're going to find less and less knee revisions because we're using more and more cementless knees, as we do with hip replacements. So when I first started here, there was cemented hip replacements, there were half cemented hip replacements, or there were old style hip replacements where the cementless stem wasn't really that well engineered and they failed, right? Now, today, with the stems we have and the cups we have, you don't really see too many hip revisions anymore. We're revising the old ones, but not any of the newer ones. And I think that the same is going to happen in the future with cementless knees, where the main failure is that cement bone interface where we cement it, it becomes loose, like he said. And I don't think we're going to see that anymore, right? And another, I want to just expand a little bit on what you said. You know, patients will come to the office and say, well, I have this little thing here and this hurts here, or it hurts here, or when I go down steps, it hurts. My question to a patient that I can automatically throw away that we're going to have to do a revision is I say to them, are you feeling much better now than you were before the surgery? And they go, oh my God, I feel 10 times better than I did. Right then and there I say, that patient does not need a revision. Because everybody who has a replacement will know and will say, there's a little something wrong, because it goes back to my statement earlier, God gave us the best set of joints you're going to ever have. A replacement will have, someone will have some complaint about a knee replacement. Now, we try to tweak things so you have less and less and less and less complaints, and it's better and better and better. But when you get to the point on your knee replacement, you say, oh my God, this feels worse than it did or the same as it did before my surgery, that's when we have to start looking at why is this happening and what can we do to make that better.
How long should I wait until I get a second opinion?
I will pretty much see anyone, but I think for the first year, if you go to somebody else, because I like to give it a year to see, I mean, unless there's something catastrophic wrong, because I always tell people, at a year, you're going to feel a lot different than you feel now. If they're still feeling bad at a year out from the surgery from someone else, then I'm happy to see them.
What kind of restrictions will you have following a knee replacement?
I always tell people, you can kneel. You're not going to damage your knee. Gardeners, Catholics that in church. I mean, it's important. That's important for people because that's part of their that's their life. That has a lot of meaning to them. People of Asian descent who do a lot of prostrating and kneeling. You can kneel, but it might hurt you to kneel, but it's not going to damage your knee. And it's amazing. Some people can kneel without a problem. Some people have problems kneeling. My gardener is always like, I have to kneel because I garden, right? So it's important. So we do our best with the understanding that you just might not be able to. Some can and some can't. As far as lifting, do you have a lifting?
So
I
always
say 20, 50 pounds.
I always say that a total knee is not a motor. It doesn't get you up. It doesn't make you faster or jump higher.
Exactly.
All it is a crown on a tooth. If you have a crown on your tooth, you have to chew the food. All that is a crown on your knee. The only lifting weight restriction is your muscles. So as strong as your muscles are, you can lift what your muscles allow.
What is the latest advancement in knee replacement?
Okay. So I'll give you the update on the modern knee. So we put up all of those things in the beginning. The biggest difference in the modern knee replacement, the biggest advances are pain management, non-narcotics, outpatient replacement, new technology. We don't cement in. We let it grow into the bone. We have less bone removal. It should be called the knee resurfacing and not a knee replacement. We have partial knee replacements. If half of your knee is worn out, we could do a partial knee. If the whole knee is worn out, we'll resurface the whole knee. Our anesthesia is unbelievable. We stopped doing general anesthesia most of the time. We do spinal. Our biggest advances are pain management, anesthesia, early rehab, no inpatient rehab, nutraceuticals. We have all this in our joint camp. So actually, we stopped those before the pandemic, and we have handouts in the office. So we could literally talk on any of that but those are the bullet points of the modern knee replacement. So
most people think, it's amazing how many of my patients think, well, they'll say, well, tell me about the knee replacement. They literally think you cut the knee here, and you cut the knee here, and you take that out, and you put it, how many people here think that's what you do? I'll bet you some people think that. Yeah, exactly. But it's actually like Tom said, right? So this is your femur bone. So what we do is we make certain cuts in the bone. We take out that arthritic bone. We cut it out, just the surface. And then a cap, just like he said, fits on the femur, right? That's one metal piece. And then the tibia bone, we make a flat cut, and we put like a dish or a saucer of metal on the tibial side. And then in between is a plastic sandwich. And so now, instead of your arthritic bone rubbing up against your arthritic bone, you now have metal rubbing up against plastic, and you don't feel that. And that's really what a knee replacement is. And a hip is pretty much the same thing. A hip is a type of resurfacing.
And there's a schematic of it.
And there's a schematic. So see, you can see it just kind of fits right on, right? And a hip replacement, right? This is the neck and head, and this is your acetabulum, your cup. We cut out that neck, take it out, we put a stem down with a ball on it, and that's your new head and neck. And for the cup, we put a metal cup in and a piece of plastic, and that's your new joint. So again, another joint. Instead of the bone rubbing up against the bone that causes it to hurt, you now have metal or ceramic rubbing up against plastic, and that doesn't hurt. And that's what a replacement is. So if you have a bad joint, there's three things we can do. We can cut the joint out, remove the joint, right? We can replace the joint, or we can fuse the joint. And when I say fuse the joint, we just make it so you can't move. Because that's three ways to alleviate joint pain. And what we found as joint surgeons, the best thing to do in most cases is to replace the joint. And that gives you the highest quality of life and the highest functioning life.
Are there varying types of prosthetics used for joint replacements?
No, you're going to get the plastic one.
But
or the tin. We have a tin one for Medicare patients.
you know what, Eric? It's actually a good question.
It is a good question.
Because what's the most common operation in the country? Cataracts.
Yep.
What's the second most? Knee replacement. In cataract surgery, you could get the generic Medicare lens, or you could pay $5,000, or you could pay $10,000. But in the knees, they're frankly the Ford, the GM, and the Chevy of the trucks. They're basically all the same. There's no outcome difference of the modern knee replacement. So it's a great question. Unfortunately, our government and Medicare and Medicaid does pay for those. So good question.
Can BMI be too high to have a joint replacement?
Do you know where BMI came from? It came from a Belgian mathematician 200 years ago that wanted to come up with a formula to relate your height to your weight. It had nothing to do with population health. So somewhere along the line, about 50 years ago, Ansel Keys came up with the idea that the BMI should be related to population health. BMI is no more related to your health than your heart rate as a single variable. But insurance companies like to use these things to limit care. And so as a single variable, I really don't have a limit. But we do use a lot of common sense because a lot of people with a high BMI do have other problems: metabolic disease, high cholesterol, high blood pressure, heart problems, venous stasis in their lower extremities. So it's really the constellation of all the comorbidities. But as an isolated BMI, and some insurance companies, and Eric will tell you, they'll have a BMI of 41 and they refuse it, and the other patient will have a BMI of 50 and there's no issue. So there's no absolute dogma on this. I think as a general idea for your health, excess weight causes aging of every joint, and I think you're better off post-op getting it down, but it answers the first question we started about, which is dogma, and a lot of this stuff isn't based in fact.
So is it an insurance?
It's insurance, yeah, and some doctors have their own opinions, and their experience, maybe they've had higher infection rates, higher wound healings, because there are statistics that show that. Usually higher BMIs are associated with type 2 diabetes, which has some other issues, so all those things go hand in hand. You have to have a good discussion with your surgeon instead of a dismissal, oh, you're too high, and you're not a candidate. That's how I think of it.
I think it's a conversation that has to be had with all patients, right? We have to care for the patient, okay? And I think that, isolated BMI is one thing, but the bottom line is people with elevated BMIs have problems. They have problems with other issues. They have problems with their hearts. They have problems with diabetes. They have problems with wound healing. They do. So I can have that conversation with the patient and talk about risk. You always look at risk to benefit ratios. If the risk is much higher than the benefit, you're not going to do it, right? So don't do it for your own body. I applaud you for losing 80 pounds because that's going to make a big difference in your health, right?
Yeah, and I definitely can tell that would make a big difference in recovery.
Huge.
I happen to love this topic, and I talk about this topic openly with my patients because I think obesity is a very big problem in this country. I think that the pandemic, they messed up big time, right? They locked us up in our houses. They didn't talk about things, right? One of the biggest factors was multiple comorbidities, and one of those was morbid obesity. BMI is greater than 40. And another comorbidity, your chances of surviving COVID were much less than someone that's healthy, right? So I love to have this conversation with my patients, right? Obesity causes two issues, right? Everybody will understand this. The one thing that obesity causes is you're carrying extra weight, right? So if I tell you, here's a backpack with 50 pounds in it, go for a walk. Carry this around with you for the day. Your knees are going to feel that, right? Your hips are going to feel that. But what patients don't realize is, so that's the biomechanical part of obesity. But there's also a biochemical part of obesity, right? Especially that centripetal obesity or centripetal adiposity, the fat around our guts, right? That's actually pro-inflammatory. And you have a lot of inflammatory factors that flow throughout your whole body, and that's what people don't realize, that's really the connection between heart disease and obesity, joint disease and obesity, and diabetes and obesity, because it's all centered around chronic inflammation. So if we can do things to help improve our chronic inflammation, then we're going to help with our post-op rehab, we're going to help with the surgery itself, and we're going to help with our overall health. So that's what the conversation that I always have with my patients regarding obesity.
So we're coming up on an hour. Let's go 2 more questions and then we'll close it.
Are there any contraindications with joint replacement?
It's very, 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 very rare. Some guys make a living off of telling people that they're rejecting it and they take it out and put a different one in. There are so few people that are allergic. The other thing that I know people in the audience hear about is nickel. I'm allergic to nickel, right? How many people here are allergic to nickel? I'll bet you someone will raise their hand. I know it. And I'll bet you $1 that you're not allergic to nickel for real. But There are studies that show even patients that are allergic to nickel that have a knee replacement don't reject the knee replacement. They do have nickel-free knees out there, and anybody that has a nickel allergy, I do put a nickel-free. No knee is nickel-free, but it has very little nickel in it. But true people that are allergic don't wear any jewelry, nothing, no jewelry. You guys have jewelry? You're wearing jewelry? I bet you that jewelry has nickel in it. Bet you all the money in the world. No, I'm just saying people that are allergic to nickel.
I have very crazy allergic.
Yeah.
So I'll tell you, and I'll complement that with, there's no more biocompatible material in the body than metal. Metal is so benign in the body. And metal sutures used to be around way before the sutures we use now, and they're the most compatible with the body. So there's no cells, there's no immunity, there's no rejection on these with the modern components. Last question.
Are stem cells used to regrow cartilage?
So there are some research centers that are making scaffolds, and they're putting cartilage cells in there, and they're recreating the meniscus. It's really not out there for the masses. There's no long-term data. This is research stuff. There's nothing better than the future of stem cells, but the stem cells out there now are scam artists in these things. But in the bench research, there are some things going on, but it's not marketable commercially. And most people in this room that need a knee replacement, when they come in on bone, no matter what they invent, they will never have a scaffold or cartilage because it's too late. It will be for those younger knees that have a isolated meniscus that they could replace. But I want to thank everybody. I want to thank Dr. Lebby. I think we got more information answered and answered your questions in an hour than if Eric and I gave a lecture, and most people fall asleep with that. So I appreciate you coming. I like this forum. We could probably do it for more hours, but we may even reschedule another one. But thank you very much for your attention. Eric, thank you.